Hello and welcome to EBC 2020 Medtronic sponsored symposium Advancing Left Main PCI. My name is Goran Stankovic. I'm international cardiologist from Belgrade, Serbia, and it's a pleasure to work and discuss left main PCI with my colleagues and friends, Dr. Mirvat Alasnag and Dr. Tom Johnson. This is the agenda of our session. So I will initially discuss anatomical challenges of left main and quickly go through EBC consensus on left main PCI. After that, Tom Johnson will speak about state-of-the-art evidence for left main PCI. Then Mirvat Alasnag will present complex left main case, and we will discuss the strategy, and we will discuss how to improve EBC consensus based on the most contemporary strategies and techniques used. I will end up by wrapping up and sharing learning resources. Left main is different bifurcation because it has certain anatomical characteristics. Compared to other bifurcation, the main difference is large proximal main vessel with large discrepancy in caliber between proximal and distal part of the main vessel. Then compared to all other bifurcations, B angle between LAD and circ on the average is 80 degrees, so it's T-shaped angulation. Left main is also the area prone to calcium deposition, so it's very frequently calcified. Ostium could be involved, and side branch is never small because side branch is circumflex. In 10% of cases, there is also trifurcation, which may have influenced our decision-making and the strategy. So these specific anatomical characteristics have significant impact on the stenting technique because POT becomes mandatory and the essential step, and we also need to consider stent design with large diameters necessary to cover left mains, which goes up to 6 millimeters. Then because of T-shaped angulation, we need to be careful when selecting the strategy. Aorto-ostial involvement is characterized by higher elastic recoil and the risk of longitudinal foreshortening, and also in calcified lesions, a lesion preparation is the key for successful stent deployment. EBC has published recently EBC consensus document on left main PCI, and one of the main messages is that in left main disease involving both branches, stenting techniques should depend on individual patients' anatomical characteristics, but we need to take into consideration also the operator skill. However, our general strategy for left main, as well as for all other bifurcations, is provisional. But provisional, although standard strategy, is actually treatment philosophy, and it's not just technique of single stent. We start by stenting main vessel, respecting distal main vessel diameter. We do POT to respect the original tapering, and then in case side branch is compromised, we continue with dilatation. If still compromised, we do side branch stenting using T-tap or culotte. And this is our algorithm based on the risk assessment for losing the side branch after main vessel stenting. So if we don't expect the high risk of losing the side branch, our standard strategy is provisional. And then if second stent in the circ is necessary, we do T-tap or culotte. If we have major concern regarding losing the side branch, then we can either start by double kissing crush or by inverted provisional, and then again finalize by inverted T-tap or inverted culotte. So I'd like to conclude that for left main PCI, provisional side branch stenting is recommended for majority of lesions. Stent technique should depend on individual patient's characteristics and operator skill. Elective two-stent strategies may be considered for important side branch with complex and extensive stenosis, difficult side branch access, or high risk of side branch compromise. Among two-stent techniques, there is strong randomized evidence for double kissing crush, while EBC main results are awaited. Thank you very much for your attention. The second lecture will be presented by Tom. Tom, please.
Goran, thank you, and thanks for the invitation to join you to discuss the state of the evidence in advancing left main PCI. 5 minutes for this is a somewhat tall order, but I'll do my very best. So I think since we met last in Barcelona, there has been some fairly major fallout, and the EACTS meeting of 2019, apparently inspired by Genius, led to the most incredible fight really between intervention and surgery, to the extent that in the UK there was some fairly damning news reporting, particularly BBC, where heart doctors were said to have held back stent death data. And as a consequence, it was highlighted that the surgeons had withdrawn their support from heart disease advice. And we saw around Christmas time this withdrawal of the EACTS support for the 2018 myocardial revascularization guideline. And so this was a fairly troubling time, and particularly with this accusation of the fact that intervention carried greater mortality. Now, since then, there has been some further work done, and this is a meta-analysis published by the Imperial CRF group in the European Heart Journal, which reassuringly highlighted equipoise really in terms of mortality associated with percutaneous and surgical revascularization. However, I think we have to acknowledge as an interventional community that there is a hazard in terms of unplanned revascularization in favour of bypass surgery, and we really need to improve our consideration of patient selection and enhancement of techniques, as Goran has already alluded to, the techniques that exist for left main stem PCI. So where are we in terms of evidence? Well, we've published actually from the UK data set an all-comer outcome report from the British Cardiovascular Interventional Society, a 4% absolute reduction in mortality to 1 year with the use of intravascular imaging for unprotected left main stem. There have been reports previously, but this is fairly compelling in terms of supporting an image-guided approach to the use of intervention in left main stem. Now that very much fits with the South Asian experience, and we see in Korea a 75% penetration of IVUS guidance use. And this is a nice report comparing provisional versus two stent technique in the left main, taken from two large registries in South Korea. And again, importantly, highlighting this relatively low mortality, similar between single and dual stent. We see no difference, although numerical difference, in terms of target lesion failure in favour of provisional approach. There is this striking signal of target vessel myocardial infarction, I think, highlighting the complexity of intervention, both with provisional and two stent approaches. And then we see out to 36 months hazard in terms of target lesion revascularization. Again, not significant between the approach of a single or two stent approach, until they broke it down to looking at simply the second generation DES population, or just over 700 patients, where we see a favour for the provisional, the simpler approach as supported by EBC for treatment of left main. Now, contrary to that, then we've had, again, contemporary data published from a Chinese group, Definition 2, comparing again provisional versus two stent strategies for complex bifurcation, of which about 30% were left main stem and truly complex, 85% Medina 111. And we see there then two stent technique favoured over provisional, with this quite striking target vessel myocardial infarction rate very early associated with the acute intervention. And this is somewhat puzzling in the setting of two stent approaches which are procedurally more complex, take more time, and interestingly also in a population where imaging was only adopted in a quarter to a third of patients. Now, if we turn back to the Korean experience in terms of IVUS, we know that there is a kind of mandate to try and achieve this 8-7-6-5 MSA sizing of left main, polygon, LAD and circumflex. And there's been some very nice data published now from the Noble study looking at an IVUS subpopulation, and in fact highlighting this discrepancy between the Asian population and maybe a European population, where the MSA value in left main was actually around 12, 16 in the polygon, 10 in the LAD, and just under 10 in the ostium of the circumflex, so far exceeding, in fact, the rates that were suggested as the kind of standard to be met by this Korean study. And there are only a small number, 3 to 5, 7% of patients that failed to meet the 8765 criteria. Now, the Noble Group have interestingly then broken this MSA into terciles, and we see that with the highest tercile, the largest MSA, no events in terms of left main target lesion revascularization out to 5 years, against where we have a smaller MSA here of 10 in the left main against the 8 that was given as a standard in Korea. We see a much greater hazard. So I think we're evolving our technique, evolving our strategy with the use of intravascular ultrasound in left main. And really the point I'd want to put across is that we often talk about optimization by imaging, and we should shift that to guidance. And we see here a difference between patients who had no IVUS use against those who had IVUS pre and post deployment of a stent, and then have used before or after, but not in both, a fairly matched result. But really highlighting this importance of using imaging from the beginning to the end for lesion characterization, for vessel sizing, for stent optimization. So I think we've had an interesting year in terms of state of evidence. I would suggest that comparison of surgery against intervention is unfair. It's comparing apples against oranges. I think what's come out of this argument, though, is that patient selection is essential, and there's a crucial role for the heart team. So patients should be discussed and patients should be given a choice. But mortality, importantly, there's equipoise between the two strategies. We have to acknowledge PCI is complicated by target vessel failure, myocardial infarction. Provisional versus 2-stent role, I think we've seen data that can support either, and we await EBC main. And then following that, I think absolutely there is a role for image guidance to enhance outcomes. I thank you for your attention.
I'm going to present a case where we did left main bifurcation stenting using DK crush technique to treat osteostenosis of the left circumflex coronary artery, and hopefully highlight some of the points that were mentioned by Dr. Johnson in his presentation a few minutes ago. This is a left main bifurcation where we elected to do a DK crush on circumflex. This is a gentleman who was 65 years old, presented diabetic, had preserved left ventricular function and normal kidney function. He presented to us with angina, chronic stable angina, and an angiogram showed a chronic total occlusion of his LAD, and this was in 2012. So at that point in time, we opted to have dual access and kind of do the usual PCI. This patient required re-entry with a stingray, and then we ended up stenting the patient. We tried to nail the oxygen all the way back to the left anterior descending artery, maintaining the circumflex as is. And this was the final shot in 2012. He did well for about 2 years when he came back to us again with chest pain, and we did a relook, and this is what we found. We had the LAD and the LAD stent was widely patent, but now we see a disease or focal stenosis of the ostium of the circumflex. So I think here and perhaps open it to discussion.
Yeah, thank you very much, Mirvat. I think excellent first recanalization. Looks like stent in the LAD was perfectly open. I think procedural result look great. I don't know if you did imaging at the end of the initial procedure, but now I'm sure we need some more data in order to make appropriate understanding of what was the reason for failure. And it's a pleasure to have Tom Johnson as the first author of the recent consensus document from EAPCI. Tom, what can you share with us about this case?
I think firstly, I urge Mirvat not to cut herself up too much about the fact that you tried to nail the ostium. I think it looked reasonable as an approach in 2012, that there was sufficient landing zone. I guess that in terms of re-entry, dissection re-entry, I mean, you entered the subinterval plane, I guess, in the proximal LAD segment. Looking at this lesion now, the worry is that there's been plaque shift or there's been progression of disease due to traumatization at the ostium of the LAD extending into the circumflex. And clearly now that we have a stent at the ostium, it makes intervention slightly more challenging in terms of strategy. but I think, as Goran says, we need more information probably. For me, the most compelling data was presented in the EBC Consensus document for IVUS use in left main stem, which showed that by using imaging, we highlight much greater complexity than the angiogram allows. So I'd be very interested to know what the ostium of this LAD looks like, and the disease burden at the distal left main, because clearly that's going to influence your strategy in terms of how you treat this by a second stent.
Thanks, Tom. Let's see what Mirvat has actually done at that time, and let's learn from this particular case of a failure at the ostium of the circ, which is really very frequent in our practice. Mirvat.
Yeah, so at this point, we addressed surgery with the patient and the surgeons, as a matter of fact. So the patient was always reluctant to undergo surgery. It was a very emotional issue for him. He had a family member that didn't do well, and so he really didn't want it. But when we had a more objective discussion with the surgeons, their concern was, you have an LAD that's widely patent, an LV function that has not changed in the last 2 years, and a patient who's coming with chronic stable angina, and they were, you know, reluctant to take him to surgery for only a circumflex. So we discussed complex PCI of the left main with the patient and the surgeons, and that's where we decided to go on. Unfortunately, I don't have the IVUS imaging for this patient, but we opted to, since this was ostial circumflex disease, we wanted to make sure we cover it, and there's no geographic miss of the ostium of the circumflex, and felt this, and it's a sizable circumflex, felt the more suitable strategy here would be a DK crush. So what we ended up doing is dilating the ostium, wiring both vessels. So we have to wire in the LAD and the circumflex. We pre-dilated the circumflex. We positioned the stent and determined the length that we wanted. It had a balloon in the LAD, ready to crush afterwards. And afterward, deploy the stent in the circumflex, making sure we actually covered the ostium safely. And as I mentioned, there was a stent that was already across, there was a balloon already across that, ready to crush. So once that was deployed, we did our post-dilatation and then removed the hardware from the circumflex and went ahead and crushed the circumflex stent. So this was the first crush for this patient. We rewired both of them. We did kissing inflations over here, and we went ahead and started positioning a stent that went across the circumflex. So you can see that the wires and the that was in the circumflex had been removed at this point, and we're trying to determine the position of the stent that was going from left main into the LAD. At this point, we ended up deploying, and so you can see the second crush. It's probably easier in the LAO caudal view. You can see the crushed stent in the circumflex. And then we went ahead and did our proximal optimization, and where we did dilatation of this stent that was in the left main. Before we even wire the circumflex, it just feels easier. We don't end up wiring underneath any struts in an under-expanded stent in the left main. So that's what we were doing here. This is the pot itself, the dilatation. Once we had a wire across, we did our second kissing inflation at this point in time. We did a pot one more time over here, and it's very important to determine, to make sure that the ostial struts are dilated appropriately, and we make sure we also know where our carina is right now that we had. And this was the final result for the LAD circumflex DK crush this time around. So I think we have a lot of information now where, as Tom was telling us just a few moments ago, about the utility of intracoronary imaging. And this is perhaps a good time for us to discuss at what points we want to stop, do some imaging to help us guide and not just optimize these kind of complex procedures.
Yeah, thanks, Mirvat. I think it's really excellent final result. And also by your CT that was done at the end, you confirmed the position. I will start first by asking how you select devices, mainly the stent. It's a large left main. What was your selection? And a second question is, I'll let Tom discuss imaging, but my question is related to, you did 2 times kissing, and recrossing in kissing in decay crash is specific. We learned from Shaoliang Chen that we should aim for crossing proximal strat for the first kiss and maybe mid-central strat for the second. Is that also your practice? You are one of the experts for decay crash. So for the benefit of our audience, please share stent selection and recrossing.
Yes, so for the stent selection, it's important to decide that ahead of time. So it's important to make sure not only the diameter, but the appropriate lengths of the stents that you have and the balloons that you're going to use for both the kiss and the proximal or pot. You have the appropriate lengths that are not going to encroach on the carina. And a lot of the new generation stents, the majority of them, you know, will expand appropriately. So what we actually ended up doing is you saw this was a very sizable vessel. We ended up with a 4.0 stent that we post-dilated to 5.0.
Excellent, yeah.
Balloon in the left main itself. And for the kiss inflations, we, you know, we use both balloons, but moderate inflations in both vessels.
Yeah. And the second question is, when you recross into the side branch, in decay crash, you try to cross proximal. Is this also your practice?
Yeah, we're learning to do that as well. But, you know, it's always easier to kind of cross with the loop, try to go into the main vessel and then kind of pull back and cross in the appropriate segment. I think when we try to do it by eyeballing, it may be a little bit difficult. I think sometimes we're able to use stent boost and, you know, a clear stent, depending on the
yes.
you have. But I'll probably stop here and turn over to Tom to talk to us about the different phases of intracoronary imaging where he would recommend that we go ahead and use either IVUS or OCT to help us through the steps.
Sure. Well, I mean, I think it's a really nice case, Mirvat, and the bit that strikes me most is this discrepancy between the left main size and the LAD, which Goran has highlighted in the very first introductory slides. And so clearly the decision-making in terms of an appropriate stent matrix that is going to be able to expand sufficiently for the left main, but be appropriately sized for the LAD. And so the first part of the imaging is to use it to make those decisions. So to understand the nature of the disease, but most importantly then to appropriately size. We're still learning in terms of using the imaging for the purpose of wire positioning, and that's part of the October study, which hopefully we'll have reported sometime soon in the future. I mean, looking down this OCT image reminds me of the Visible Heart Lab, which I think you may well have some images to share, but you know, we have so many opportunities to get this wrong that we have to take care with every step. And so what imaging and certainly the resolution of the OCT images you're showing here provide is a very, very careful approach to ensuring that we make safe decisions each and every step. So here we see this beautiful illustration of the clustering of struts around the side branch. I'm honestly not sure, Goran, about proximal or mid-cross or which is the right place to go, because I don't think we can ever truly predict how the crushed stent in the side branch behaves. There's every chance you pull it off both the proximal and the distal edge of the side branch ostium. And so I think there's hazard, and we have to acknowledge that hazard every time we do these cases with or without imaging, and just take the greatest care we can. And so the stent device actually plays a very, very important part in this, in terms of the way that it conforms. And this is a very nice example of how here the onyx is in theory, you know, going to expand very significantly in the left main and potentially open up a much more sizable opening to the side branch for rewiring and ballooning for the secondary kiss.
Thanks, Tom. So Mirvat, any final remarks?
Well, I mean, See, this is actually what you were talking about from the heart lab. This is an image that actually shows when we do the appropriate dilatation, proximal optimization, we have more control over the wire recrossing. Again, it's a lot more theoretical where it eventually crosses, but we should try every effort at least to make sure that we're well expanded, the struts are open, and so we can safely deliver equipment without jamming anything. You know, just to give you a final update on this patient, naturally we had our threshold to relook is always low. So he came again in 2018 with chest pain. Fortunately, again, his you know, LV function was normal and troponins were normal, but we did relook and his stents were widely patent and he's doing very, very well. So I'll kind of leave you with that here.
Great, thank you very much, Mirvat. I think this was a great demonstration of the most contemporary approach to distal left main treatment with double kissing crush as one of the standard strategies for diffuse circumflex disease, and also optimization of the result using OCT and imaging assessment of stent position inside the left main. Because of a huge discrepancy between diameters of the left main and the ostium of the LAD, I think mandatory use of imaging should be strongly recommended, as stated also in EBC Consensus documents. However, DK crush is currently the best validated two-stent strategy for the left main, and we still await for the results of the European Bifurcation Club main. It's the study comparing randomized comparison of single versus dual stenting strategy for true bifurcation left main coronary lesions, and we intentionally used, because of this discrepancy in diameters between left main and the LAD as well as the circ, we used Resolute Onyx stent, which is now CE marked to expand additional 0.25 millimeters across the side matrix from 2.0 to 5.0, and it's purposely designed for extra large vessels like the left main, with 4.5 and 5.0 diameters now being able to expand up to 6 millimeters. And 2.0 millimeter design also can expand up to 3.5 for tortuous and tapered extra small vessels. I'm happy to share with you that study recruitment is completed on December 1st, 2019. So I would like to congratulate the top 3 recruiting centers, and we really await February, March next year to see the results of this important study and to understand if also in European centers DK crush and two-stent strategy performs better than provisional. I would like to invite you also to attend Bifurcation Exploration website, and you can access all those nice images from the Visible Heart Lab, as well as step-by-step description of all contemporary used bifurcation stenting techniques. I thank you very much for participating in this webinar.